go. So the purpose of this little video, and I'm going to try and keep it to about 5 or 10 minutes, is to go over the transfer medication guideline that's at the end of our protocols and just talk about each of the medicines, not to reiterate what is in the guideline itself, but just to talk about some of the other things that are nuances of each particular medication. So as you all know, I'm very wealthy and have affiliations with multiple of these medications because I own a bunch of drug companies, so I have to tell you that up front. All right, so the first group, I've broken them down into groups as best I can. I'm going to start out with miscellaneous because these basically don't have any tie to the other medicines, and then we'll knock some of the other ones out. So this group, though, includes antacids like Protonix, which we may see as an infusion running on someone with a GI bleed, for instance, going from Georgetown to the University of Kentucky or elsewhere. And you're really not going to have any problems with this medication. So I don't think there's anything in particular to this or medications like it, which would include Zantac, Pepcid infusions, things like that. So this group, I think there's nothing to worry about that. But having said that, anyone who has a medication reaction or what is perceived to be a medication reaction who's even on something like Protonix or another antacid, which is generally well tolerated, the first step is to just shut the infusion off and then to address any symptoms that someone may have. Okay. All right, so we're going to move on to antibiotics, which we have been giving cefazolin, also known as Ancef, in the field to open fractures for a while here as part of a study. I think we're doing that in affiliation with the University of Kentucky. But Ancef is from a group of penicillin-like antibiotics, and penicillins as a group do cause quite a few allergic reactions, and I think we know how to treat those. Again, the first step is shutting off the infusion and then treating any serious allergic reactions with epinephrine and fluids, and then things like itching with Benadryl. So let's see. We may see in this class are medications like Zosyn is a very commonly used penicillin that treats almost everything. You know, there are a few things that it doesn't. Keflex is the oral form of Ancef or cefazolin. Another one that you may see that's very commonly used is something called Rocephin, and that is again in the penicillin class and fairly broad spectrum. I want to talk about vancomycin a little bit because vancomycin is used commonly. It treats skin bacteria, so staph and strep, and in particular it treats MRSA or methicillin-resistant Staph aureus, which a lot of other antibiotics don't. And so one thing that's peculiar or particular to vancomycin is that it can cause red man syndrome, and we are in an era of political correctness, so this has been renamed to Flushing syndrome, not like the toilet. Flushing syndrome is exactly what it sounds like. It's where patients have basically capillary dilation of the skin, and their skin becomes very red. Very rarely will you have hypotension or other symptoms related to this. It's not an allergic reaction. It has nothing to do with histamine, as measured by histamine concentration in people who are having this reaction. It is, however, very rate dependent. Of course, for us, I see no problem with just shutting it off. In fact, that's what I would recommend. In the hospital, where it's a little bit easier to treat folks with this, what we typically do, if we don't think it's an allergic reaction but do think it's a red man syndrome, then we will slow the infusion down, which tends to alleviate the symptoms of this problem. The next thing in this class is insulin, and we're going to see a lot of insulin drips, and it's not just for hyperglycemia. You can see insulin drips related to hyperkalemia and a host of other problems, including beta blocker overdose, things like that. And insulin drips, of course, we need to monitor someone's mental status for decline, and probably be checking blood sugars at least once or twice during the transfer. The other thing, as I said, insulin is used as a medication to treat hyperkalemia. So even when you're not treating hyperkalemia, if somebody's on insulin for hyperglycemia, DK, or whatever, insulin can cause hypokalemia. We are not really going to, it's going to be a tough one to figure out. If an EKG is done, you can see subtle things like the sort of area under the curve of the T wave gets smaller with hypokalemia, things like that. But of course, hyperkalemia is much more dangerous, and I wouldn't worry about that. I just want to bring it up that that's something that can happen. People can have cramping related to insulin therapy because of this, though, and we can treat that with either fluids, pain medicine, just analgesics like fentanyl, or again, if someone's not horribly sick, we can stop the drip, or we can stop it, period. How about that? Okay, the next thing on the list of medications is magnesium, and magnesium drips are started for a host of reasons also. We use it, of course, for eclampsia. That's probably its most important indication. We also use it for things like cardiac arrhythmia, specifically torsade du pointe. So this medication can cause loss of reflexes. It can cause visual changes, probably related to extraocular muscle weakness. And it, ultimately, because the diaphragm is a muscle, magnesium infusions and hypermagnesemia can cause respiratory paralysis. So, you have to monitor someone's airway. I'm not going to advocate that we check reflexes, things like that. And hypermagnesemia is very well tolerated until it causes respiratory suppression. This is of more concern, quite frankly, in the hospital, where providers are not at the bedside. But we will recognize this and can stop the infusion and put the person on oxygen and just monitor their airway for ventilatory status, basically. So I think that magnesium is actually a safer medication for us to infuse, again, because we are right with the patient the whole time. Okay, the last one in this class is potassium. And potassium, as you know, is generally used for hypokalemia, or low potassium. But again, it can actually be used along with insulin to treat beta blocker overdose. And we are not going to be able to monitor really for hyperkalemia related to this. You sort of can by doing EKGs and looking for the opposite of hypokalemia, which we talked about earlier. In hyperkalemia, or high potassium, you will see peaked T waves, and the area under the curve of the T wave is going to increase with hyperkalemia. And one thing in particular I would like to mention about this medication is that, and I think a lot of us know this already, is that infusing potassium actually causes quite a bit of discomfort. It's very caustic to the veins, and so people having this medication infusing will complain of pain at the site of the IV. Slowing the infusion or diluting it, which I wouldn't recommend that we dilute anything, obviously, but we can slow the infusion. And we can ask the hospital to administer lidocaine through the IV prior to transfer to help with this. And any arrhythmias that are encountered while transporting someone on a potassium drip, I think I would not recommend discontinuing the drip because the most common indication for a potassium infusion in the first place is hypokalemia, which can cause premature ventricular contractions and other arrhythmias in the first place. So it's unlikely to be related to hyperkalemia. Hyperkalemia, as we talked about, will start with sort of peaked T waves and then progress to QRS and QT prolongation, and ultimately will result, at least on the EKG, in sort of a sine wave tracing, which is extremely concerning. And anything like that that's seen during transport, I would definitely recommend discontinuing the infusion. So that's it for this first class. Thank you.